Now let's talk about, again, the risk management hotline. And this is important. Again, I want to emphasize one thing that's particularly important with the risk management hotline, and that's the confidentiality. So if you call into the risk management hotline, you're going to speak to somebody who is knowledgeable in ophthalmology, who has gone through a number of cases, who have seen problems, who have been well educated and spend their time reviewing the particular problems. And in addition, they will be speaking to you and not speaking to any of the rest of the company unless you specifically state that you need additional help or need to be referred to another area of the company. So there is a firewall built between the hotline and the remainder of the company. Now, what do they offer? Well, they offer lots of different particular helps. For instance, they'll help with general questions, general risk questions, some guidance as to those questions. They'll talk to you about incidences. That's where you think there may be an issue that's come up. Talk to you about what's occurred, give you some confidence, give you some backing as to your particular problem, which a lot of times, especially when you think you're having a difficulty with a particularly difficult patient or a difficult colleague, can make a world of difference. They'll also review documents for you. So if you have a new consent form or if you have a new procedure and you have questions regarding that, send them into the hotline. They'll be glad to review those things for you and give you their best impression as to what should be done. And sometimes, unfortunately, we all have trouble with even colleagues who, for some reason or another, may speak badly about us or may be doing things in the community that we do not fully appreciate. And we need to speak to someone about, how do I handle that situation? What is your recommendation? And of course, these folks have lots of experience regarding that particular issue. Now, some of the problems that are called into the hotline are ones that can be easily dealt with, but then there are other problems that are called in that are fairly frequent. These frequent problems I would like to highlight at this time. One of them is, of course, the sidewalk consult. We all face that. We all have sidewalk consults and really can take one of two directions when somebody wants to, quote, talk to you off the record. One direction is that it may come from an attorney's office, where an attorney, either for a patient of yours or maybe not even for a patient of yours at this point, wants to talk to you off the record. All of it just between you and they. First thing you have to understand is there is no such thing as off the record. If you speak with the attorney, everything is in fact on the record. You have no relationship with that attorney. So there is no attorney-client privilege in that particular case, and they can use or not use anything that you discuss with them. Sometimes they call in about care that you provided and simply want to get a few things cleared up. And so a lot of times folks will want to sit down and talk with them because they just want to resolve the issue as quickly as possible. But again, realize this person is not necessarily representing you, and in fact isn't representing you at all. And you'd have to be particularly careful regarding that issue. Sometimes they're calling in to discuss a patient that you have, but the care that was given by another provider. So all of these are considered to be particular consults or sidewalk consults from an attorney. The other type of curbside consult obviously comes from other individuals, other practitioners, even emergency room physicians who call us and just ask our opinion about a particular case. But let's talk about both of these particular issues. Again, when an attorney calls in and says, may I speak to you off the record? May I go over something with you? Again, realize there's no privileged communication here whatsoever. And in fact, even if your patient has said, doctor, I'm perfectly happy for you to speak to my attorney. In fact, I'd like for you to speak with my attorney. You're absolutely under no obligation nor duty, even if the patient has authorized that communication, to speak with them. And in fact, sometimes attorneys get hostile and they say, well, if you don't talk to me, then I'll just depose you. I'll set up a deposition to depose you. Fine, there's no problem with that, then depose us. And in fact, the best thing to do in either case is simply call OMIC. The hotline or the risk management department can certainly give you a lot of guidance, but I would be particularly careful if someone's being hostile or someone's being aggressive. I would make sure that I called OMIC to get their opinion. Furthermore, I would be particularly careful about commenting on the care given by any other provider. Again, many times all that we have as physicians from our patients is their history of what happened with the other physician. We don't know what happened in the interval. We don't know what surgical procedures were exactly done. We don't know what the complications were. Unless we are speaking with the other physician, we simply don't know. And it's inappropriate for us to make some sort of conjecture as to what we think occurred. So most of the times it's better just not to comment on that behavior whatsoever. Now, your office can be directed to give sort of a stock response, which is Dr. Fouraker in this particular case has a long-standing policy of not getting involved in legal matters of any of his patients. This policy allows him to devote all of his time and attention to providing quality care for the patient. That's perfectly appropriate. Many times I want to, and I'm sure most of us do, want to be informed if an attorney is called to speak with us. And we want to certainly direct our staff as to how we want them to respond to that particular issue. Now let's switch gears a little bit. Let's say a sidewalk consult or a hallway consult, or you get a call from an emergency room. Typically there's some dissertation by that individual as to the history of the patient, the findings that they have seen on that particular patient, and any test that they've run and their interpretation of it. Realize that I keep saying their interpretation, their history, because you're not obtaining the history. You're dependent upon whatever questions they asked, whatever their understanding of the patient's response was, as well as whatever their findings were on their exams. And all of us know that there is a tremendous variance in the quality of the exam that can be done by other people. Sometimes those quality exams are quite good, sometimes they're not so good. But you are dependent upon those individuals and what they've seen to make your decisions. So a lot of times they're calling you and they say, we would just like your advice, but you're not actually billing for any of this advice. And because you're not billing for any of this advice, there's actually no patient-physician relationship typically ever established. So you would think that if you give advice and something untoward were to occur, that you're off the hook. Not always. There are cases in which you're impleaded into the proceedings because you're being called by either the emergency room or another colleague to ask for your advice because you're the expert. And they're going to follow your advice. They're going to follow what you have said or what you have told them because you're the expert. So be very, very, very careful to document when you're called in these particular cases as to what you understood that they told you, what the circumstances were, and what your advice was. This is particularly important with the emergency room. Many times, I've, in fact, recently been called by an emergency room who indicated to me they had a patient, had some decrease in vision. They had done a Woods lamp and seen that there may be a little epithelial defect, but the patient was in a little more pain than they would typically expect. And they want to know, can we just have the patient come over and see you in your office tomorrow and take care of the problem? In that particular case, I actually went into the emergency room to see the patient. And they did, in fact, have an epithelial defect, and it extended all the way through the cornea, the iris, and the lens. What really happened was that a branch hit the individual patient in the eye, rupturing the globe, and the vision, which was recorded at 20/40, was actually more like hand motion. But I happen to know the emergency room, and I happen to know the individual who is calling me, and felt like I probably ought to check on this. And of course, the epithelial defect was still there after I closed the open globe in surgery that night. But of course, it was important that I went in there and saw the patient. It's also important that I documented exactly what was suggested to me. It's important that you document when you're called all the things that you were told and the advice you gave. Many times I'll give advice and I'll have the physician or the emergency room physician or whoever has called me repeat back to me what it is that I just told them. What's your understanding of what I suggested to you? And they'll repeat it back, and you'd be surprised how many times it has very little to do with what I just told them. And so it's important that you be very careful with that. Now, what if they keep over and over and over calling you and saying, well, I've still got this problem, that problem? My suggestion is very straightforward, which is that at that point in time, you have the patient referred to you. Please just send the patient over, or please send the patient to me for a more formal consult. Otherwise, I would keep these conversations very brief. I try to limit the amount of information and advice which I provide to them, and I would keep the number of conversations as short as possible. If you get a lot of conversations, it's time to refer them.